So my name is Luisa Belloni. I'm a project officer with the PIP Framework Secretariat, and I will guide you through the PIP 101 today. I have quite a few slides. I'll try to go quickly with the introductory slides, and then you have questions. We will save some time at the end. So the outline of the presentation, we have an overview of influenza work at WHO, and then we will go to the PIP framework overview and its benefit sharing mechanisms, the partnership contribution, the SMTA2, the governance of PIP, and then what's next. And I've included one slide with some useful links. So to move on, WHO and influenza. Influenza is a unique, highly contagious and infectious disease. WHO has done a lot of work on flu, and it's among the few known pandemic-prone pathogens. As you know, the question is when and not if the next pandemic will happen. Global prevention and control is coordinated by the WHO through a network of labs. It's the Global Influenza Surveillance and Response System, or GISRIS. Some numbers on seasonal flu and pandemic flu. It kills quite a lot of people every year, and it has killed 52 million people in the past 100-year pandemic flu. GISRIS, as I mentioned, it's a network of public health labs specialized in influenza. It's been working for over 70 years, and it works as a global alert and response mechanism. It does year-round continuous virus detection, sharing, risk assessment, and pandemic and epidemic response. We currently have coverage in 130 member states, supporting 160 labs who work under the WHO terms of reference. They can be found, the pandemic component of which can be found in Annex 5 of the PIP framework. There are 4 different categories of labs. We currently have 152 NICs, National Influenza Centers, 7 collaborating centers, 4 essential regulatory labs, and 12 H5 reference labs. To note that some of the labs serve in more than one capacity. For instance, the CCs, the collaborating center, often also serve as NICs and or as ERLs. So to move on PIP, so what happened? That one doesn't work anymore. Oh yeah. It's fine, it's still here. Okay. So why was the PIP framework developed? I think it was mentioned earlier this morning that there was a reemergence of avian influenza A H5N1 in the early 2000s, also known as bird flu, and in 2006, as was mentioned this morning, Indonesia, a member state, started questioning the fairness of the global influenza surveillance system. So it is really thanks to these concerns that were raised about the access to vaccine, the virus sharing on one side, but the access to vaccines and questions about supply and the cost of vaccine. And that prompted WHO member states to recognize the need for a fair and more equitable system. The negotiations started around 2007, and then the PIP framework was adopted by the World Health Assembly in 2011. What is the PIP framework? The PIP framework is a landmark innovative public health arrangement whose objective is to increase global preparedness to respond to pandemic flu. It is an access and benefit sharing system for public health. It is the only existing system for public health, ABS system for public health currently. It has 2 objectives that are to be pursued on an equal footing. The first being the strengthening of GISRIS, done through the timely sharing of influenza viruses with pandemic potential, or IVPP. The second objective is to increase equity of access to pandemic response measures, such as pandemic vaccine. It is a partnership. It brings together member states, industry, civil society organizations, and other key stakeholders, and obviously WHO, who is tasked to implement the framework. Among its guiding principles, we can find transparency, equity, and partnership. Equity really is at the core of the PIP framework. So how does it work? As I mentioned, it's an access and benefit sharing system. So on the access side, we have the virus sharing, where countries share their viruses, including the IVPPs, with the GISRS network. And then GISRS labs, they do a number of things with this material, one of which is to develop the CVVs, the candidate vaccine viruses, which are then shared broadly, including with manufacturers who use the CVVs to produce the pandemic vaccine, the seasonal and pandemic vaccine. On the benefit sharing side, so in return for sharing their viruses, countries can expect to receive supply of vaccine and other pandemic response products from the WHO during the pandemic. And this is done through the SMTA2 process, which we'll see in a second. The other benefit that countries can expect in returning for sharing their viruses is to see their capacities supported and strengthened through the partnership contribution, which is the annual monetary payment that manufacturers make to the WHO. So a little bit more in detail on the access side. As I mentioned, it's the virus sharing. So under the PIP framework, member states are expected to share their IVPPs in a rapid, systematic, and timely manner with the GISRS labs. And they do so with the expectation that some benefits arising from the use of such viruses will be fairly and equitably shared through the PIP framework benefit sharing mechanisms. The GISRS labs, as I said, they do a number of things to these viruses. They do risk assessment and they develop the CVVs, which are shared with the manufacturers. Also to note that all the transfers of PIP biological materials, so we're talking about physical viruses here, they're recorded in the IVTM, the Influenza Virus Traceability Mechanism, which was put in place in 2010. And it's a database where the GISRS labs record all the shipments of PPM. You can access it through this link. It's publicly available. On the benefit sharing side, there are two key benefit sharing mechanisms envisioned by member states through the PIP framework. The first being the partnership contribution, and the other is the standard material transfer agreements. So one benefit is for the here and now. It's the partnership contribution. We collect annual payments from influenza vaccine diagnostics and pharmaceutical manufacturers that use GISRS. And the funds are used to support countries to increase their capacities to respond to a pandemic influenza. The standard material transfer agreements, SMTA2s, these are legally binding advanced supply contracts, which are signed with manufacturers to provide WHO with a certain percentage of their future pandemic response production in exchange for receiving the PIP biological material. So to note that there are two different triggers for the two benefit sharing mechanisms. For the PC, it's the use of GISRS, whereas for the standard material transfer agreements 2 is the receipt of the physical biological material. So this slide summarizes what I just said. It's just to reinforce again the message that PIP is an access and benefit sharing mechanism where access and benefits are placed on an equal footing. On the access side, we have the virus sharing done through GISRS, and on the benefit sharing side, we have the PC and the SMTA2. We'll go now into the two benefits a little bit more in detail. The PC, the partnership contribution, this can be found in section 614.3 of the PIP framework, which says that influenza vaccine diagnostics and pharmaceutical manufacturers that use GISRS will make an annual payment to the WHO. This is known as the partnership contribution. So use of GISRS is not clarified in the framework itself, but the definition of use of GISRS was developed in 2013 in collaboration with stakeholders. And it has been interpreted as including receipt of PIP biological materials, but also the use of GISRS data and information. So it includes the use of GISRS IVPP GSD. In terms of amount, the amount of the PC is determined to be equivalent to 50% of the GISRS running cost. This, again, is prescribed by the PIP framework. It is currently at 33.7 million. To note that it was 28 million until last year. There is a footnote in the framework that explains that the GISR's running cost may change over time, and so the PC will change accordingly. So there was quite a lot of work done in the past few years to update the level of PC. This was done in collaboration with stakeholders and especially, obviously, manufacturers. How do we divide the total annual amount among the contributors? This is done through a graduated PC formula, which is based on influenza product sales. So companies that make more sales will contribute more, whereas companies with less sale will contribute less. It's a graduated system. And again, the PC formula was developed in collaboration with the stakeholders back in 2013. The PC funds are collected by the WHO, and they're used for 3 different things. Most of the funds are used to improve preparedness and response capacities in countries where they're weak. A percentage of the funds is put aside in a response fund, and we will use it for future pandemic influenza response. And then they're used to support the work of the PIP Secretariat. The allocation of funds is based on multi-year high-level implementation plan, what we call HLAPs, and these plans are developed in collaboration with partners. We're currently on the 3rd HLAP, which will go through 2030. As of today, we have collected around 345 million. This is a figure as of 30 June 2025. Moving on to the SMTA2. As I mentioned, these are legally binding contracts which are signed by the WHO with all the known GISRS entities that receive PIP biological material. Notably, these are vaccine, diagnostics, and pharmaceutical manufacturers. The purpose of the SMTA2 is to establish an equitable, predictable, and structured access by the WHO to future pandemic response products such as vaccine, antiviral, and diagnostics. These products are supplied in real time to the WHO, so especially for vaccine, they're supplied to the WHO as they come off from the production line. And they are distributed free of charge to countries based on public health risk and needs. As I mentioned, we sign SMTA2 with all the entities that receive PIP biological material, and we classify the entity into 3 different categories. We find what we call category A is the vaccine and antiviral manufacturers. Category B is the diagnostic manufacturers, and then category C encompasses all the other entities that receive PPM, such as academic and research institutions. And so the manufacturers can select among benefit sharing options that are based on their nature and capacities. So category A, B, and C, they have a range of different benefits that they can select from. Also to note that we sign the SMTA2 with entities that receive PIP biological materials, so only the physical material. However, once the agreement is signed, we will receive a pandemic vaccine regardless of the technology that is used in the production of such vaccines. So once the agreement is signed, even if manufacturers will produce mRNA vaccines and not using the traditional technology and not accessing the PPM, they will supply vaccine to the WHO. This is just a summary slide of where we are now. We happen to be at 100 exactly as of yesterday. Signed vaccine. This includes category A, B, and C. We have 16 SMTA2s with vaccine manufacturers, 2 SMTA2 with manufacturers of other pandemic products, and 80 with the other institutions. We also have 2 other agreements. We call them other agreements because they don't really, they're not really technically SMTA2s. They fall into a different provision of the PIP framework. So these were negotiated with contracts with manufacturers who signed that on a voluntary basis. They are still legally binding contracts, but these companies were not required to sign an agreement with the WHO. That's why they fall into a different provision. In terms of benefits secured to date through these agreements, we have secured approximately 11% of future pandemic vaccine production, which translates on a best case scenario and based with current technologies in approximately 900 million vaccine doses. We have also secured 25 million syringes, 250,000 diagnostic kits, and then up to 5 million treatment courses of antivirals. I just want to mention this. This is an implementation challenge, what we call the interim process. It's related to the SMTA2 process, and it's an example of how we had to find sometimes creative processes to implement the PIP framework because the framework itself prescribes that PPM can only be shared if the receiving non-GISRS entity has signed an SMTA2 with the WHO. This is prescribed by the framework, but as we started implementing it in 2011, it became quite evident that this condition would have significant implications for the timely sharing of viruses and for public health more generally. And so the WHO worked with partners and especially with the GISRS labs to develop this interim process to allow the shipments of PPM to continue while the SMTA2s are being negotiated. So now the GISRS labs can ship the PIP biological material even if the prospective recipient hasn't signed an SMTA2 yet, but there is a shipment notice that goes with each of shipment, and this is to alert a potential recipient that the PPM that they have requested entails some obligations under the WHO PIP framework. And the notice indicates that if the recipient does not agree with such obligations, it must cancel its request of shipment of PPM from the GISRS. And this approach has allowed important virus sharing to continue while the SMTA2s are concluded, so that critical public health activities that rely on access to PPM are not compromised. So moving on to the governance of the PIP framework. The PIP framework has a robust governance system. It's based on a 3-pillar oversight mechanisms where we can find the World Health Assembly, who oversees the implementation of the framework, the Director General, who promotes the implementation of the framework, and then there is an advisory group who provides evidence-based reporting, assessment, and recommendations to the Director General regarding the functioning of the framework. The AG meets twice a year in Geneva. It receives update and briefing from the Secretariat, and it's composed of 18 members, which are drawn from 3 member states from each of the 6 WHO regions. It's made up of policymakers, public health experts, and technical experts in the field of influenza. The members serve between 3 and 6 years, and the main function of the group is to monitor, assess, and report the implementation of the framework and to provide recommendations to the DG. Examples of AG recommendations include how the PC funds are used, the proportional division of the funds between preparedness and response, and commitments around the SMTA2s. It's really a valuable group of experts that provide not only recommendation to the DG, but also really valuable advice to the Secretariat. And I just want to mention the advisory group work on GST. We have heard a lot about GST and DSI today, so I think it's important to mention something about the PIP-AG work on GST. It was mentioned before today that PIP was designed for physical material, PIP biological material. But between 2009 and 2011, when the PIP framework was adopted, questions around GST started arising. And so member states did recognize that further work would be needed to resolve the handling of GST under the framework. And so they requested that the DG consult with the PIP-AG on the best processes for further discussion and resolution of issues relating to the handling of IPPP-GST under the framework. This is found in section 5.2.4 of the framework. So there isn't any specific benefit sharing mechanism for the use of IPPP-GST currently under the framework. However, as I mentioned, the concept of use of GISRs in the context of the PC has been interpreted and implemented since 2013 as including IPPP-GST. And this has allowed the Secretariat to contact entities that are using IPPP-GST, but that not necessarily receive PIP biological material from GISRs. And we have asked them to contribute toward the PC. And then something specifically on the PIP AG work on GST. The AG has done a lot of work on GST since 2013 through several technical working groups, and they have worked on the matter of handling GST under the PIP framework, and particularly on the feasibility of benefit sharing from its use. The AG held consultations with databases housing IPPP-GST, and they observed, among other things, that the objective of benefit sharing may be met by monitoring products generated by using IPPP-GST, what they call downstream use, rather than by tracking the use of GST, which is much harder to trace and track each use of GST. And so as part of this work of trying to monitor the use of GST in end products, we have worked with the World Data Center for Microorganisms, WDCM, to develop a prototype search engine. I'm talking about work that happened around 2015, 2016, just to put it in the right context. And this prototype search engine is a centralized web-based search engine that retrieves information on use of IPPP-GST from publicly available documents. For instance, scientific publications, patents, or regulatory files. And the aim is to find entities that have developed commercial pandemic influenza products using IPPP-GST, but not using PIP biological materials. Otherwise, we would be able to track them through the IVTM. The search engine was found to be a useful tool for monitoring the development of influenza products manufacturers by companies using IPPP-GST. It has some intrinsic limitations, which include that in order to be more comprehensive, users should consistently identify the sequence that they use through a unique identifier or providing a database accession number. And currently, there is no consistent practice of such identification. And then the second limitation is that for the search engine to be able to retrieve data from databases that require user to register and accept a user agreement, such as GISAID, terms would need to be negotiated and access granted by the database in order for the search engine to be able to retrieve data from such databases. I will just conclude with a final slide about PIP and PABS. I don't have the answers. I am just posing some questions for the group to discuss. The development of the PABS system obviously has raised a number of questions about what's the relationship with PIP and PABS, and member states will need to discuss what's the scope of the PABS system. Should PIP become part of the PABS, and if so, when? And then whether there should be a unitary benefit sharing system covering all pathogens with pandemic potential, including influenza, or whether PIP should stay a separate system. I think, yeah, I have just one final slide with some links of all the documents that I've mentioned throughout the presentation. Thank you very much.